So we are starting.
Yeah. Hello and welcome to Health Live at Seniors Today. It's been an amazing journey that we've had with Seniors Today. We've just completed uh, 5 years of existence. And the health webinar series, as you all know, has been around since we've been going relentlessly since June 2000, since June 2020. We've been having this session every Saturday at 5 p.m. And today we are delighted to have a veteran doctor with us, Dr. Alan Almeida. Dr. Almeida is section head nephrology and consultant nephrologist and transplant physician at the PD Hinduja Hospital and Medical Research Center in Khar, Mumbai. He is an MBBS and MD in internal medicine from the GS Medical College in Mumbai, an MNMAS in nephrology, and a postdoctoral fellow of the University of Missouri in the US, and a fellow of the Indian Society of Nephrology. We have Dr. Almeida here, and he's going to be speaking about understanding chronic kidney disease, which is called CKD, causes, symptoms, and diagnosis. Welcome to Health Live at Seniors Today, Dr. Almeida. How have you been?
Thank you so much. Thank you for that kind introduction. In our conversation just before we started this session, I learned a lot from you about how and what you're doing, something which is really worth looking forward to, especially when I grow older than what I am presently today. So you have set the ball rolling by indicating, do you see my slides?
No, we are not seeing your slides now, but we can switch to it now.
Okay, 1 second.
So as Dr. Almeida sets up his sites, do note that this session will be the recording of the session. Share screen, Doctor.
Yeah.
The recording of this session will be live on seniorstoday.in on Monday evening, so you can have a look at that. Don't worry about taking notes, etc. And you can ask all your questions live on the chat window. Put your question in the chat window. Do remember, this is a session that is advisory in nature, so we will not be able to give you specific diagnosis, etc. For that, the real thing, that is meeting the doctor personally, is important. Any doctor in your cities, but you can be free to ask any questions to Dr. Almeida. He is one of the senior most nephrologists in the country, and we have him here. Over to you, doctor.
Thank you so much. Now you can see my slides?
Yes, we can see it, yes.
Okay, great. So as you've already so rightly mentioned, this cannot be a consultation for your personal issue, but what can be done is broad discussion. So I would definitely welcome questions from the audience after I've made my short presentation. This is the title of my talk for today: Understanding Chronic Kidney Disease, its causes, symptoms, and diagnosis. Yeah. Well, thanks to our kidneys, we have our toxins and excess water removed from our body. Also, the kidneys balance the acids and bases in our body, and also other electrolytes. You've heard of sodium, that's part of salt, potassium, etc. Also, our blood pressures are maintained by our kidneys functioning well, though this is always bone of contention between the cardiologist and the nephrologist. I believe firmly, being a nephrologist, that the seat of the problems with blood pressure is the kidney. Now, the other problem, the other function of the kidney is the formation of a factor which is important in forming the hemoglobin. And that factor is called as erythropoietin. Also, especially as we grow older, and I am also in the same group which I'm addressing today, that we are looking towards our bones. One fall and we would be having fractures if our bones were not in the proper state. And also, once the drugs are ingested in the body, they don't just hang around there. They have to do their job, and either the drugs or the metabolites are excreted in the urine. Now, how does chronic kidney disease present? Now, I always look at chronic kidney disease as a situation in which the kidneys have failed. And when we ask the patient, do you have in the past ever experienced an acute kidney illness? And when that illness had recovered, did you go on to this at some later phase of your life? Or they could be a stuttering progress towards kidney failure. And that could be in patients who have got stones or recurrent urinary infection, all conditions in which there's inflammation and swelling of the kidney, especially of the filters within the kidney. That is, I refer to as the glomerular diseases or the glomerular nephritis. But unfortunately, at times, there's a sudden recognition of a failed kidney. It's an incidental detection. You go in for a health checkup or for some intercurrent illness, and you find that the kidneys are not working well. So we have two types of illnesses or kidney dysfunction. One is the acute or the chronic. The acute means something which is taking place over a few days or maybe a week. And the chronic is something which we will define in the following slide. Now, there is a decided move to switch away from what you would have probably heard in the past of renal. Renal means nothing but kidney. But kidney is more understandable to the one who is listening to what is being told. So it's acute or kidney injury or chronic kidney disease. So it's disease, and we don't use the term as failure because that is a term which connotes a outcome which is not what we are looking for. Now, in the past, we talked about acute or recoverable or reversible kidney disease or acute or recoverable or reversible renal failure. And the other one is a chronic or a progressive, irreversible kidney failure. So how do we define chronic kidney disease? I'm going to introduce you to some terms. Glomerular filtration rate. The kidney consists of filters, and these filters, the filtrate traverses tubes, which ultimately land up pouring out the filtrate into the collecting systems and out through the ureter to the bladder and out into the exterior part of the body. Now, the glomerular filtrate, that's the glomerulus, is the filter of the kidneys. So whatever filtrate forms, if all the filtrate passed out, you would be passing as high as 170, 180 liters of urine in a day. But no, the tubules which collect that filtrate modify and reabsorb certain substances as well as water. Now, we will see in a subsequent slide that the glomerular filtration rate varies with the stage of life, with your age. Now, when you have a glomerular filtration rate which is less than 60 and you have just that, a glomerular filtration rate less than 60, we call it as chronic kidney disease. However, if the glomerular filtration rate is more than 60, then and you have evidence of kidney damage, such as the presence of protein or blood, or even maybe an abnormal renal ultrasound and pathological abnormalities, the biopsy, then, and if these have been existent for more than 3 months and there's a progressive irreversible decline in kidney function, then we consider this as a chronic kidney disease. Now, this glomerular filtration rate, which I mentioned right up here, is based on creatinine. Now, creatinine levels at various stages of life, or the production of creatinine in the body, varies. Again, I will show that to you in a subsequent slide. So just remember GFR and evidence of kidney damage. And for chronic kidney disease, it's more than 3 months duration. So this is what I was mentioning about. Formerly, these used to be called as CKD stage 1 to 5. And the G stands for the glomerular filtration rate. And this is what you would see. And you would see that G1, G2, 3A, 3B, this has been divided 4 and less than 15. And you can see below that, I talked about the other evidence of kidney disease. That's namely the loss of protein in the urine. In this classification, which has been given, which suits our purpose well, and which helps us communicate or to realize at what stage of the disease that we are, there's also the addition of this albuminuria, or that thing, but a type of part of the proteins. And this also, depending upon how much of the protein or the albumin has been lost in the urine, can be divided into A1, A2, and A3. So if you had a patient with a G3A, that means they would have a GFR in this range. And if they had an A2, then they would have a protein in this range. So this is how, depending upon the GFR, as well as the presence of protein or albumin, which is lost in the urine, we can determine what is the degree of severity and follow up this patient. So now, why values which we obtain by creatinine-based equations which are used for calculating GFR need interpretation by a specialist? As you will see, as you go down these, as you age, there is a decrease in the creatinine excretion. So the creatinine levels, which are 0.81 here, but that is when the production was 1862. Whereas over here, when at age 75 to 84, the creatinine just marginally increased. But at that stage, the amount of creatinine which was excreted in the urine was much less. So this just tells you, see the creatinine clearance, which is again a measure of the GFR, falls from the 25 to 34 age group to the 75 to 84 age group. Now, what are the implications of aging kidney changes? We all know that we age. Now, when we age, we expect a decline in the GFR or the function. So there is, however, no way when you can reverse the age-related declines in GFR. Neither can you halt it. So if you age, you have to age and age gracefully. The age-related reductions in GFR could require medication dose adjustment for certain drugs. And the lower the GFR puts the older patients, older adults at higher risk for an acute kidney injury. That acute kidney injury is an insult to the kidney, resulting in an acute, I talked to you about hours to days to a week, in which the kidney function falls. And that is because you don't have any kidney reserve, because you have already, due to the aging process, lost some of the function which you had when you were 25. So overall, however, the age-related declines has little or no effect on life expectancy. Now, how do we know about these age-related declines, which is normal? We get all this information from studies which have looked at the pre-donation, I mean here, the organ donation, GFR, and this should be appropriate to donor's age. Now, when some patients come in and they want looking towards a kidney transplant, and we ask them who are the potential donors, they will give ages of the donors which were in excess of 60, and we would say, not too good. Then we will look at what is the GFR in relation to what they are expected to be. So if it is in line with what we expect that GFR to be, then these patients would, these individuals would still be considered to be good donors for the recipient whom they have come forward for. So just looking at this is from the British literature, and this is the measured GFR. And you can see from the age of 20 right up to 80. And you can see the decline in both males as well as in females. Females usually have a slightly lower GFR than the males. And you'll see the 70, where you say, oh, that means this is so much down. But it's appropriate for the age of 80. So this is just to illustrate the fact that related to the normal aging process, GFR decline is noted with age. So this are two pictures. On the left is the normal kidney, and on the right you find a kidney which is slightly smaller in size and which has got a granular appearance. So this is the type of kidney which would be expected in patients who have undergone a nephrosclerosis or a thickening of the vessels within the kidney. So what happens when our kidneys fail? Well, all hell breaks loose, because then the internal environment in which our cells are working, active, they have a disturbed internal environment, and the function would then be hampered. Now, what are the common causes of kidney disease? I talked about acute kidney injury. Now, that could be either because something wrong has been taken or administered, or the condition in which it was administered were not appropriate. Like if your volume depleted, then certain drugs may have more of a harm on the kidney. Or they could be urine infection and resulting in sepsis, or there could be an obstruction to the urinary tract. That means the urine which is being formed in the kidney is not going down, or there could be heart failure, an acute heart failure, wherein the heart cannot pump enough blood to the kidney. So the kidney does not get enough blood, does not form enough urine, does not throw all the waste, etc. Now, here is something which is really going to be in the future, going to be a cause of concern, not just to the world, but especially to India. We are the diabetes capital. So we have a lot of patients with diabetes and hypertension. In our dialysis units, you'll find that more than 30 to 40% of patients are diabetic patients who have gone on to kidney failure. Also, you would expect with these patients with diabetes and hypertension to have cardiovascular disease or any vessel disease, which could result in damage to the kidney, the renovascular disease. Renovascular disease means the blood vessels going to the kidney get narrowed. So the blood going to the kidney would be reduced, and that would result in consequences within the kidney. Glomerulonephritis. I talked about the filters, the glomeruli. Now, these could get inflamed and the whole kidney could become swollen. There would be leak of blood and protein in the urine. Or there could be something like autoimmune diseases or kidney stones. Or if these kidney stones moved and they blocked off the tube running from the kidney to the bladder, or from the bladder to the exterior, these would give rise to back pressure changes, which would hamper the kidney function. Now, later in life, as I was told that this is a forum for the senior citizens, and that's where we have these issues come up in a big way. The urinary incontinence, the male or the female, we have, subsequently you will see the stress urinary incontinence, the urge incontinence, etc. Not to forget that there are hereditary kidney diseases, one of which I've identified here is the autosomal dominant polycystic kidney disease, wherein there are cysts which replace the normal kidney structure, And ultimately, these cysts go on to enlarge and you have big kidneys. Now, this doesn't only affect the kidneys, but can also have in the other organs within the body and even affect in the brain. And then as you go later in life, you could have drugs, which I mentioned earlier, which can give rise to I talked about the filter, I talked about the tube, and I talked about the tissue between the tubules. Now, this tissue is the interstitium, and that can get inflamed at times, maybe allergic. And there are certain other malignant conditions which like multiple myeloma, in wherein there is a group of cells which produce certain substances, which certain proteins which get deposited, mainly light chains, which are deposited within the tubules and block off the tubule. So all these could be causes for the kidney disease. Now again, for the senior citizens among us, all of us would above the age of 60 or diabetics or obese or hypertensives or those who have had an established cardiac disease or had cerebrovascular accidents, or smokers, or those who have had a history of acute kidney injury. If you remember, one of the previous slides mentioned acute reversible or recoverable kidney injury. Yes, but in patients who have had this acute kidney injury, they could have in later life chronic kidney disease. And when you have patients with diabetes, obesity, hypertension, these predisposed to chronic kidney disease. And the last one is family history of kidney failure. If there's someone in the family who has suffered kidney failure, you need to be extra careful and have yourself screened and treated appropriately. So what are the symptoms of chronic kidney disease? Now, I've just put all together. So some patients, unfortunately, are symptomless and may present when the kidney function has failed or when complications develop. There are urinary symptoms, passage of small or large quantities of urine. That's oliguria and polyuria. This is the terms used. Or you might go many times to pass urine, or you pass a urine and your spouse will say, what is the soapy water in the toilet bowl? Or you increase urine at night, quantity or frequency. That means you go more times, you pass less urine, or you pass a lot of urine. Or there's a difficulty in passing urine. In the US, they would ask you whether you can knock the bark off the tree. If this sort of urine flow is to that forceful, or is there a smooth stream, or is it interrupted? Or you may have blood in the urine, or you may pass stones. And sometimes there's increasing weight, which is accompanied by swelling on the face or feet and a shortness of breath. Appetite is poor, you're nauseous, vomiting, hiccups, loss of weight, the altered taste in the mouth, a metallic taste. And your smell at times smells, your breath at times smells like urine. And itching, which is all over the body, and cramps or achy muscles or bone pains, and difficulty in getting up from the squatting or climbing stairs And there's an altered sleep pattern. There's a reverse sleep. You sleep during the day and keep awake at night. And there's easy fatigability and loss of a concentrating capacity. So, now, I talked about urine incontinence, and urine incontinence is an unintentional passage of urine. And there's a stress incontinence where you leak whenever your bladder is under pressure, for example, in coughing or laughing. Or there's an urge or urgency or incontinence when urine leaks, sudden intense urge to pee or soon afterwards. And overflow incontinence, wherein the bladder is not emptying itself completely. So it is going on accumulating and leaking small quantities. This usually would be with a neurological condition. And total incontinence, that bladder just cannot store any urine. So how do we go about identifying the presence or the stage of kidney disease? And we have common tests which are done, the urine analysis, the measurement of how much protein we're excreting, either in a spot urine or in a 24-hour sample. Then there are various blood tests for anemia, for etiology of the kidney disease, the blood urine nitrogen and creatinine, or BUN and creatinine as often mentioned, the electrolytes, which I told you are cleared by the kidney, bicarbonate, which talks about what is the acid-base status of the body, calcium, phosphorus, albumin for the bone profile, uric acid, iron studies. We can do sonography and Doppler, as well as certain other radiological tests to investigate the kidney. Cardiogram and a 2D echo tells us about the presence of accompanying cardiac disorder. And viral markers, why I mentioned viral markers here is that when you have a patient who has got a progressive chronic kidney disease and are likely to land up on dialysis, you need to vaccinate these patients against hepatitis B early before the kidney fails or the kidney function worsens. Because as if they are vaccinated early, then this vaccination is successful. The body produces antibodies. So there are changes in kidney with age, which may be in the size of the kidneys, the volume of the kidneys, and some instances, there's development of cysts in the kidney. And I've seen this just today. There was a gentleman who came to me, and he had a single simple cyst in the left kidney, and he had psoriasis, and he was perturbed by the fact that there was a cyst in the kidney. But the exact description was a simple renal cyst in the kidney, even though it was of substantial size. So those type of cysts can be seen in kidneys which are aged. So as I mentioned, from third to fourth decade of life, you have a drop in the kidney function. We roughly say that after the age of 40, you lose about a ml per minute of kidney or GFR per year. If the GFR decline is, however, accompanied by protein loss, then this could be due to a disease state and not natural aging. So in natural aging, you get decreased GFR, but no proteins. Now, the other problems with the kidney as it ages is the inability to handle sodium. So unable to tolerate an acute reduction in the salt intake, or an impaired ability to rapidly excrete a large sodium load. This is how the body maintains the balance. So if this kidney is not working properly, then you have all these issues. Or you cannot concentrate the urine or dilute. So you take a lot of water, you must pass a dilute urine. But if this doesn't happen, then you will have the internal environment being upset. And also sometimes because of the damage to the kidney, there may be difficulty in handling potassium, which is a poison to the heart. So this was basically the topic covering, but here we talk about one aspect I wanted to talk about was the geriatric issues of falls, polypharmacy. You need for many conditions, you need to be treated, frailty, which I mentioned about the bone disease, bone health, nutrition, and the mood. Then you've got cardiovascular factors, symptom management, electrolyte management, goals of care, the mineral bone disease, which I talked about, and anemia management. So this all constitutes the management of the chronic kidney disease. And this again, I found a very nice acronym, which be active. Blood pressure control, manage hemoglobin by use of erythropoiesis stimulating agents. Management of acidosis. Acidosis, the bone buffers the acid, so bone becomes weak. Management of cardiovascular disease, which is accompanying the chronic kidney disease. Then timing of access creating. This is when you know that your kidney function is deteriorating. You choose the opportune time to create that access for dialysis. Iron supplementation and insulin management in diabetics. Vitamin D, again for the bone disease management, and eat a proper diet. So with age and CKD, age is a significant risk factor for CKD. With aging, combination of age and cardiovascular disease in the genesis of CKD. And screening helps to identify CKD in all those with risk factors. So my take-home message to you would be, take care of your kidneys, for they are your faithful companions through life. Thank you.
Thank you very much, Dr. Almeida, for a very detailed presentation. And you have addressed so many issues and all the uh, possible concerns that people may have. Those of you who are watching, please put your questions there. You can put your questions on meeting group chat so that we can all see the questions that you are addressing, and then I will put them across to Dr. Almeida. Doctor, we have a few questions that have come in.
Sure.
One of them, which has come by SMS, is that, Doctor, you had mentioned that there could be kidney diseases, could be by hereditary. Um, I've had concerns in my family. Is it, is it certain that I will also have problems with my kidneys?
Yeah. To answer your question, yes, I did mention one of them, which is seen quite frequently, or among the hereditary diseases, the polycystic kidney disease, which I mentioned, wherein there are cysts in the kidney. Now, in addition to that, there are other diseases which are less common, but are definitely had a hereditary basis. Now, look at oxalate. Oxalate can result in oxalate stones, and this could be inherited. So there are many conditions wherein there is the genesis of the kidney of the disease is from genetic inheritance. Now, when you have those type of diseases, they're likely to be passed on to your children. So that is what I meant by the hereditary renal diseases. There are conditions which also would be related to the glomerular diseases, certain glomerular diseases. Then there are conditions which you might not directly have inherited the kidney disease, but there could be other deficiencies, or rather some defects in your genes, which predispose you to development of conditions which are therefore, because of this mutation in the gene, predisposing you to a kidney disease.
Right. Thank you, Doctor. Doctor, you of course spoken about the preventive measures that have to be taken, that are there. But as a senior yourself, what are the couple of key things that people should be most careful about as they age? Somebody who doesn't have a problem, but could well have, given the fact that she or he is advancing in age.
Yeah. So basically, we talked about diabetes and hypertension. So
And you
many
mentioned that the India is the diabetes capital.
capital of the world,
Yeah.
right? So and diabetes and blood pressure and data which has come out from India shows that this is definitely a cause for anxiety. But leaving diabetes and blood pressure aside, what are the other things? Supposing you are not a diabetic or a hypertensive, then what I would consider is conditions like indiscriminate use of medicines, over-the-counter medicines. Now, of course, that's thanks to the government stepping in. We do have less of that happening. Painkillers, if you ask patients, they come in with what do you take? Well, when I have a little bit of body ache, I take a Brufen or a Combiflam. Or how often this has been? Oh, this has been going on for a long time. So analgesics, that's one. The second thing is some. Now I hate mentioning this, but unfortunately, I've had the occasion to see patients who have been on the receiving end of a treatment which has not originated in modern medicine, but in the indigenous form of medicine. Now, having said that, I should make this disclaimer that I am not against the Ayurvedic medicines, but they have not been researched properly. What I need to also mention is that as of today, the government has definitely stepped in, recognized that there has been use of medicines, plant-based medicines, which are not necessarily been prepared in the right format, and which has given Ayurveda a bad name. Now we know that, forget about that. Recently, there was in the newspaper, there was talk of the use of fairness cream, which was loaded with uh, mercury. And we had a young girl, not a senior citizen, who was affected, and the family was affected by that, and the kidneys were poisoned. So painkillers, these plant medicines. Then I remember a patient of mine who came in from out of the city, diabetic, hypertensive, and in the 70 plus age group, and we were all ready to prepare her for chronic dialysis. And then suddenly we decided that they were big size kidneys, so we did a biopsy. And lo and behold, we found that she had what we call as an allergic interstitial nephritis. And it was related to the use of some medicines, uh, Ayurvedic medicines taken for arthritis just before she went into kidney failure. We started her on steroids, and within uh, 24 to 48 hours, she was passing normal urine, did not require dialysis. So these basically, don't be indiscriminate in your use of medicines. Remember, it's not the medicine alone. Sometimes they could be an interaction with other medicine which you're taking, which can cause you to run into bad problems. I don't want to elaborate further. This is sort of my pet topic on medications and the kidney, but this is what I would
But
tell.
would you say that paracetamols or perhaps analgesics are the enemy number one?
They're not, see, in fact, that's the one unfortunate thing that we have as nephrologists. We don't have too many kidney safe uh, painkillers. Like we have what is called as paracetamol, which this where if it's the 500 milligram or the 650 milligram, that's fine. So paracetamol is okay. Now we have in case it's a worse pain, then we have combinations with tramadol. So tramadol plus paracetamol. These are the ones which we can use. The other ones, what I call as non-steroidal anti-inflammatory drugs, those are the ones which damage the kidney quite extensively. And if continued for a long period, could cause kidney failure.
Thank you, Doctor. We have a question from Sharda Parwal who asks, is there an alternative for dialysis process? Because it's just too painful and one has to do it again and again.
Then the alternative, if everything else is all right, is a transplant. I always make this comparison. I said, if you have a car which is broken down, what would you do? If you replace the part which is causing the problem, it's a transplant. If you take off the part which is uh, uh, malfunctioning and repair it, put it back, that is dialysis, because every time you repair it and put it back, that's dialysis. I do agree that dialysis is uh, something which is mentally stressing. And I have had occasion on at least two of my patients who, after 3 or 4 years of dialysis, decided to call it a day and stop coming in for dialysis. So the way there are now agencies in Mumbai who provide for dialysis even at home. So then you can have your home environment, your home comforts, the bed which you sleep on is your bed, not a hospital bed. The third thing is that you have dialysis, a peritoneal dialysis, which can give rise to, or which can be done at home. And in fact, peritoneal dialysis, of course, not as efficient as hemodialysis, but peritoneal dialysis is probably more appreciated by the patient because they don't have these peaks and troughs. Because when you have hemodialysis, the impurities are high, you bring it down with dialysis, so you have a trough. And then 3 times in a week, it'll be up and down. Whereas with peritoneal dialysis, the abnormal or the levels of the impurities in the blood are sort of bouncing around at a more restricted area. So they feel much better. But eventually, when if the inner lining of the abdomen, which is the peritoneum, has exhausted its exhausted itself, then you may not be able to continue with peritoneal dialysis. But transplant is first. If you have no other compelling condition which will keep you away from transplant, basically, you should be able to undergo surgery and you should have the strength to be able to go through that post-operative period.
Doctor, we have so many questions coming in that we could well go into the night. But I'm going to ask you a few critical questions which are coming.
Right.
One is um, uh, this is by Pratibha Garg, who's asked, I'm suffering from urine infection for the last 6 months now. Pus cells are normal, but bacteria are found. Is there something that you would advise?
Okay. Now, this is a good question because this is a very frequent occurrence. Now, the diagnosis of urinary tract infection can be made when you have the symptoms of urinary infection, which I mentioned, the burning micturition, the increase in the frequency, the urgent or the incontinence, all that. Plus, if it has gone on to the upper urinary tract, that's the kidneys, you could have fever with chills. And if it even goes systemic, that means throughout the body, then you can have even your blood pressure falling. Now, the sometimes a diagnosis of the urinary tract infection is made on seeing your urine routine report. And in the urine routine report, this bacteria which you mentioned are mentioned by most laboratories. Now, let me give you an understanding of what exactly happened. You have you give a urine sample to the lab. By the time that urine sample gets processed, there is a sufficient time period which is elapsed. At that time, when you remember that when you're passing urine, it's not a sterile urine that you're passing. There are bacteria which are present at the tip of the urethra or the external part of the urethra, which pass into that sample. And these bacteria start proliferating if the urine has stayed on the lab table unprocessed for many hours. So at that time, you'll find bacteria which have been reported by the laboratory. So that is one. Second thing also that comes to urine culture. The proof of urine infection is the urine culture. And the way that we do it is by collecting a clean, sterile urine, or rather a clean catch urine. Now, there we ensure that when we give the urine, it should be midstream. Midstream means when you start passing urine, you let the first part go, catch the middle part, and the last part is not caught. So the first and the last part is thrown out, and the middle part is taken up for the urine culture. Now, when even collecting the urine culture, where you should not open the bottle, you should loosen the cap but not open the bottle till you start passing urine, so that it's not exposed to the atmosphere, wherein there could be bacteria which could be grown. So this is as far as the urine infection goes. Now, when you say that you've been having urine infection for the last 6 months and there have been bacteria in the urine, you need not, it need not be urine infection. That's one thing. Other thing is, among women who provide this sample of urine, there could be contamination of the urine by the discharge which comes out from the vagina. So that is another reason. So when I look at the urine sample or a report, I talk to the patient, find out the symptomatology and what are the other pertinent information which tells me about whether this urinary sample, the report, is really accurate.
So I know we are exceeding time, but I'll ask you a few questions. One is, somebody has asked, how much water should one take, and is barley water an alternative to ensure that?
Yeah, I'll answer the second one. I'll answer this second one first. There is no special reason why you need to take barley water. You need basically water. Now, how much water to take? Well, it's basically related to your thirst. Now, in certain conditions, the doctor may advise you to drink less water. One is if you have got swollen ankles or your blood pressure is high or your heart is under stress, then you need to cut back on the water. So depending on, normally, if it was a normal person, I would say you will take 300 to 400 ml more than what you pass out. So if you pass out 2 liters, up to 2400 ml would be what you would be expected to take. If you remember my presentation, I talked about the ability of the kidneys to throw out the excess water, to throw out the extra salt. So when this has been exceeded, or rather this is not happening, then it gets retained in the body. So if you have swollen feet, I will ask you to cut back. And I will ask you to ensure that your weight comes down by not more than 0.5 kilos per day, unless you're grossly swollen. So this is the way we gauge. So use your thirst, and in conditions, health conditions, wherein there is swelling or shortness of breath or blood pressure, where you look at both salt and water, salt and water restrictions, so as to bring you back to a level which is compatible with a symptomless life.
Doctor, there's a question from Khurshid, and I'm going to just ask you for, what are the fruits and vegetables one must have and not have?
Okay, basically, the detailed answer to that would be provided by a dietitian. But what I would say, that if you have an issue with potassium, you can't throw potassium from the body, then you have to restrict yourself to those low potassium foods or no fruits. Low potassium foods or no fruits. For example, the leafy vegetables have got potassium. Certain fruits like mangoes would have a high potassium. So that is the list which is available, which every dietitian would provide. So that is as far as the food items go.
Uh, Doctor, there's a question which is coming as to uh, should be the safe creatinine levels at age 72? This is from Akori Mithunja Kumar.
Yeah. So now if you have a person who's you remember that chart which I showed you, the table, there is no as you grow older, the amount of creatine generation is is less compared to what is at 20. So you expect a 20-year-old to have a more muscular body than a person who's 70. And the creatinine comes from the creatine, which is the muscle protein. So if you have less muscle, you have less creatine. So your answer to the question is, what is the safe creatinine, is dependent upon how muscular you are, because that will be, so the other thing to do is to do what we call as the EGFR, which takes into consideration your creatinine and your age and certain other factors, one of which previously we used to use a race factor, which has now been removed, and then come to calculate the EGFR, that is the estimated GFR, which will tell us whether your creatinine is high or low or normal.
Thank you very much, Doctor. I'm going to ask you just one last question. I know you are a senior yourself. What is there one mantra or two mantras that you would recommend to our to various people who are here? We have around 150 people who have gathered here, and around 1,000 odd who are watching it on YouTube. Any one or two mantras that you practice yourself, as somebody who is a senior, and how do you ensure that your kidneys are healthy and always?
I'd look at two aspects. One is the your weight, and the second thing is your fluid output, a regular diet, and exercise. Also avoid things, these over-the-counter medications. Don't dose yourself with too many medicines. And the uh, other aspect is the smoking. Avoid smoking. Now, the question usually which follows in, what about a peg or two? And that's something which basically it's avoidable, because there's certain people who have uric acid issues. If you drink alcohol, you'll find your uric acid is bumping up. So, but what they say is a little bit of wine, that should be okay. Red wine, preferably.
Thank you very much, Dr. Alan Almeida, for being here. For a very informative session. It is our privilege at Seniors Today that we have such senior medical practitioners who are giving us their time to inform us all about various ailments that are there. Uh, Thank you very much once again, Dr. Almeida. Thank you very much to the team at Hinduja Hospital for facilitating this. We will be back once again next Saturday, which is Ganesh Chaturthi, but we'll be there. And we have a special session on dermatology. We have a senior dermatologist who's joining us from Chennai next week. So she'll be there and who will be answering all our questions on skincare for seniors. And thank you once again, Doctor, for this amazing session. As I mentioned earlier, uh, the edited video and the takeaways, which are written by a medical practitioner, will be there on the Seniors Today website on Monday evening. So you can watch Dr. Almeida's presentation once again and take down all the points. Thank you once again, Doctor.
My pleasure. Thank you so much. Happy to be with you all.
Thank
I
you
hope
so
I have helped. Thank you.
Of course you do.